is a 74-year-old male who actually presented, referred to us because of increasing dyspnea and who had a positive stress test, risk factors to diabetes, hypertension, smoking, stress test positive, inferior, lateral, and anterior, everywhere. Even the echo done outside and with us had low EF between 30-35. He had prior PCI to the ramus with the synergy stent. So he has been on good medical therapy. You can see that, the medications. So cath on 523 actually showed that he had 3 vessel disease. Left main was okay, heavily calcified LAD with a lot of disease in the prox mid and totally occluded RCA. The ramus was ISR with subtotal to total occlusion and significant disease in the circumflex. With a high syntax score, we decided that he needs to get a heart team approach, especially because he was a diabetic. So every case, we do go through the OC criteria with this patient with diabetes, 3 vessel disease would be intermediate to inappropriate. But once heart team was done, he came to appropriate criteria. And other thing that has been recently added, and we also interventionalists are paying more attention, is the surgeons as well as us is discuss what is the frailty of the patient. This patient, though is 74, did have some frailty with him. So he met a surgeon here in Mount Sinai. He met a surgeon outside a hospital, went back to his cardiologist and decided that he wants intervention. So if you can go to the angiogram now. So the angiogram. So you see his EDP, about 20 wedge, is almost less than 30 from our, RCA catheter injection, but they said about 30% or so. So if we go to the next, this is the right coronary artery that is totally occluded. You see some collaterals that's coming from the left side. So left main is okay. Before we inject tram-track calcium of the LAD, ramus, you see the stent that is subtotal and significant disease of the LPL. So this is where we are with this patient. The question is, how would we approach this case with this low EF multivessel disease, knowing that there is heavy calcium in every vessel, actually. You can also see the calcium in the prox circumflex as well as in LAD. So if you can open it to, our plan would be that we wanted an Impella guided PCI. We already did the.
Yeah, but before you go there, can we get a little discussion going? Because I think, we saw the data presented on low EF multivessel disease, but I'm in terms of revascularization strategies, obviously we're going for PCI also. I'm just seeing that these distal targets are not great either, really small vessels and the surgical discussion, and just for the sake of completeness, can you, did I miss that did the patient refuse? How was this evaluated with the frailty and everything else that you put in front of us? What was the surgical options?
No, he did. He met actually 2 surgeons, and both were ready to operate on him, but the patient refused. He did not want surgery. So he went back to his original cardiologist. So I think between cardiologist, patient, and the family, they are the one who made the decision that they would rather have a PCI. Diabetic already has a restenosis of 1 stent. We really wanted this patient to go for surgery.
Yeah, no, 100%. So, Bill, Dr. O'Neill, I'm going to put you first up before we start. I mean, you can see that's already a Impella support. And then I want to hear from Antonio. Don't know if he's using it as much. And I know a lot of you, Amir Kaki as well, probably everybody here would say, well, if we're going to go forward with PCI, given the choices, understanding that this probably is not the best way forward for diabetic patients with low EF, we want to do the very best job. So make me a case that we absolutely need protection for this PCI.
Yeah, just before that, Dr. Sharma was very depressed at the end about his study about talking about the BCS Revive. And I just want to point out to you guys, when you look at that trial, those patients were class 0 or 1. It's a very unusual patient population. They're
Right.
all asymptomatic. So I would say that this is the courage trial of high-risk PCI, because the patient, and forever we know that PCI helps symptoms. So it's either angina or dyspnea. In the PROTECT 2 study and the PROTECT 3, 80% of the patients are either class 3 or class 4, which is what we're operating on and what this patient is. Very symptomatic patient, and I think they benefit. So in this particular patient, I think, as we all know, LIMA is life-saving. LAD is what you really have to work on. And you're going to want to do an extensive atherectomy, I think, to try to get the vessel optimized. And that's really going to cause a lot of LV dysfunction. His right coronary is totally occluded. You're going to be causing extensive ischemia as you rotablate the LAD. And those patients absolutely need support.
Antonio, would you proceed without? I know in Europe, there's less of LV support with even as high risk as this.
But before deciding if I'm going to use port, I need to decide what I'm going to do. Because, the apex on the LV gram
Doesn't look like it's
doesn't look
moving.
brilliant. And always look at the LAD as my target, because the LAD is the most important. So I'm not so sure how important it is to revascularize the LAD. That's the reason why, honestly, I need some advice before giving advice myself.
Okay. Jazz, what do you think? Do you think this is a good approach? I certainly would go after the LAD, even with the apex, because we just don't know how much of it is. It seems to me this is progressive symptoms with a lot of, and the CTO was old, but go ahead.
Yeah, I think, the stress test, actually, if you looked at it, showed ischemia, very rare for it to show ischemia multivessel territory. So I think it's probably viable. Otherwise, I would have had to do viability. So if anterior wall is viable, then I think going to the LAD is important. And then, obviously this needs atherectomy. And then, as you know, atherectomy-wise, if you do, clog the microvessels after rotoblader and its CSI, probably takes about an hour to 2 hours for the reticuloendothelial system to really absorb it, and your EF even drops further. So I think support in this scenario, especially if you're doing rotoblader, is very, very important.
Amir, any thoughts there
Yeah, I think.
before we move forward?
Yeah, I would definitely use Impella. I think in this particular patient has heart failure symptoms. The more revascularization, the better. I think the LAD is very challenging and probably his most meaningful vessel that he has now, given the totally occluded right. And my only suggestion is I'm a big advocate for utilization of right heart cath. And in this particular case, it's going to be interesting at the end of the case for the reasons noted by Dr. Singh, as whether the patient should stay on support or we could take it out at the end. So it'll be interesting what the team decides.
So, Anu, you heard everyone. You've already, I don't know if you're
Yes.
done with the procedure as we were speaking, but tell us where you are and what you're planning to do.
So just by looking at the angiogram without dye, you see tram track calcium. Definitely this needs some kind of atherectomy, and look at the wiring. So we used a fine cross, and this is a fielder. So this is the tightest part. Almost we thought we may need specialty wire to cross there. And then you see how you will cross it, that you bring the fine cross all the way to the tip of the fielder wire. Again, try to navigate the fielder as well as you can. So we were able to get through that total, almost a subtotal lesion there. And then we went down, we changed to rota wire. So we have a rota floppy wire, no need to use extra support. Since we had a little trouble of the fine cross to go through the tightest area in the mid to distal LAD, we have a 1.25 bar. So we are going to do 1.25 bar, which is not probably going to do a lot in the prox mid LAD, but you definitely need something in the mid to distal LAD. So that's where we are ready to go.
So before you started, just so that we're going to watch your beautiful rotational atherectomy techniques here, but more importantly is, what was the left ventricular end diastolic pressure? How do you prep the patient? And in terms of contrast use and of course, the fact that the patient may or may not receive lots of, I'm sure you're doing some hydration and protection of the kidneys. You want to just talk about that quickly?
Yeah, so EDP is 20, and that is why I think with LV dysfunction, EDP that is high, Impella definitely works a lot. And we have a CP, which is right now working at 3.7, 3.8 cardiac output. So we have just gentle hydration on this patient, not a lot, just gentle hydration. Creatinine is about 1.1. He's on heparin because it's a large bore access. If anything happens, we are able to reverse the heparin immediately. Right now he's on aspirin Plavix, but after the procedure we can change it depending on what we want to stronger antiplatelet agent. So the 3 steps before we start rotational atherectomy was that you just move the knob backward forward, take any tension between the Teflon sheath and the bar, then here Y connector. So your bar and the wire, any tension is gone, and then we do a dyna tap, and after that we start the burring.
Dr. Colombo?
I'd like to ask a question. Assuming that the LED is the right target, why we know that when we do rotablation, we always pay a little price, sometimes maybe more than a little, in terms of embolization. Why, in this particular case, don't try first with a high-pressure balloon and see if you can get a reasonable result, maybe then IVUS and focal shock wave, in order to minimize the risk of distal embolization?
Yeah, no, this is a
We
good
call-
question, and we
we
can
call
talk
that-
about that, yes.
We call that roto regret. And everybody's been there where you got these tight lesions and you can't cross them and you push like hell for an hour and then you balloon it and then you dissect it. Okay, so now you're in a mess because you have a heavily calcified vessel that's small, that's dissected, and you can't use the rotablator and you end up with a really bad result. So at least for these diffusely these vessels, the technique that Dr. Kinney's taking is fantastic. Slowly burr across with a small, and then take a look. And the vessel is going to be much larger when you end up here. It's going to be a pretty large artery once you get the atherectomy done.
Pedro?
The comments are very good. We study the segmental wall abnormalities of rotablator with echo in the cath lab in the old days, and we saw them when compared to PTCA. Nevertheless, I am 100% with Dr. Bill O'Neill. When you think about rota, don't go back, especially in this kind of vessel. I totally agree that rotablator is the way to go. Furthermore, with those segmental wall abnormalities, what you need is to decant the ventricle or unload the ventricle, and you're doing that with the Impella. So the damage will be probably attenuated by the capacity of the unloading ventricle.
But I think it's a really good discussion if anyone here would think of an alternative plan. Oh, Kate is here too. Hi, Kate. Didn't see you. Maybe, Kate, you want to tell us how would you approach this? Would it be rotational atherectomy or other?
Wire indiflate. Why didn't you do so?
I was just thinking that in a lot of the older data, the microembolization and stenting we saw was also because of thermal energy and before we had DAPT. So I think the cases that we really worry about are when we've loaded the patient on the table and we see more issues with that. But with that and good technique as demonstrated here, I think like the acute issues that we find are quite rare, and we actually have less dissections. I also have tried, with Shockwave and implementing that in practice. These are the types of cases that I find it's so diffuse that you end up doing so much ballooning, you're bearing a guide extension for so much of the case that I'm not sure your ischemic burden is any better. So I would also proceed like this.
You would proceed like that. Dr. Reitman?
Yeah, I would agree. I mean, I think that atherectomy must be the first step here. I think for the same reasons that a mammary probably would not remain patent. Mammary would be attached at the apex of the left ventricle and sort of getting flow backwards, unlikely to be successful over the long term. I think that the high-pressure balloon and the IVL strategy perhaps appropriate after atherectomy, but getting through these lesions just to prove that we could get through with an IVL balloon, I think very, very challenging. This is a much more expeditious process. The only other comment I was going to make, as consistent with what Dr. Kaki and O'Neill were saying, the pulse pressure, in spite of the fact that This patient has a very low
Okay, give me the
ejection
balloon.
fraction with multiple regional wall motion abnormalities. The pulse pressure really suggests that this has been a more indolent process that's occurred slowly and progressively. It's
Fantastic.
reassuring.
Thank you for that. So, Anu, I'm a little disappointed. You're going straight with a balloon after just the 1.25 burr. This is a larger, I see I would have liked to see you upgrade now to maybe a 1.75 for the proximal area, because all of this needs to be at some point stented. No, am I mistaken here? And I don't know
No.
what others think.
Yeah, I think that's the discussion that we are going to have. The question is, after doing rotational atherectomy, if you see the flow is still, I'm not confident to do an OCT in this vessel yet. I think we'll have to dilate the mid to distal LAD, and then we can do the imaging to understand. And the question is that do we go with a bigger burr, or do we go with the PTCA cutting balloon, or do we need to use IVL? That should be the discussion. So I think I'm just trying to make sure the distal flow is good, and after that. we'll do
Okay,
an
so
OCT
you really
run,
want to do
if
an
everybody
OCT
agrees
run?
with that.
You know, you see that
Yes.
she took an intermediate approach.
Yeah.
You rarely finish a rotablation with a 1-5. So she has concerned about distal embolization. Otherwise, he would have gone directly with a 1.5. So I totally agree with this strategy.
Yeah, that's good. And also remembering, Dr. Colombo, what you have in your lab, we do not have. I know you're salivating over
you want
this
to
artery to
hold
just
here.
do drug-coated balloons.
Depends, it depends. This is not the time to make this decision. First,
Right.
you have to dilate the artery.
Yeah.
Now, you see that this area under action, that could be because our balloon is small. It's a 2.5 balloon. It could be a 3.5 LAD. So either that, or of course, it's a 1.25 burr, did not do anything. So we'll do imaging quickly and then decide what should be the next strategy. So I think for the people who are here who are doing rotational atherectomy, the biggest reason, why we went 1.25 and not 1.5, like Roxana was saying, for the proximal, we definitely need 1.75, but distal could have been a 1.5. When you have a tight lesion, calcified, you have difficulty in wiring, I think you always, this is the learning point here that is telling us, downgrade your burr. Yeah. Okay. Now after this, we will do the OCT. Connect this.
You have tools now that if your balloon doesn't heal, you already fractured, you did the lesion, and then you have now IVL that you can do. There's no real point in upsizing nowadays. So you just modify the plaque and use the other tools to minimize complication and get as much luminal gain as you can.
Great.
No, connect here, connect. Okay, so we're going up with the OCT. Bring this closer.
Actually, CSI is not bad for this too. You can actually use it for very long diffuse
Yeah,
areas.
I wanted
with
to
a flex
hear
wire.
about that as well, because there are so many choices here in
Right.
terms of, so would you have gone with CSI first?
Yeah, I'm very comfortable in doing CSI. There is a little theoretical benefit, the way it rotates also, that it allows flow, and in people with low EF, it actually, Impella we have, so we don't need to really worry about it. But if you don't have much reserve, there is theoretical benefit of flow. So I would do it slowly, and with a flex tip wire, it actually does very well in diffuse, and you don't have to upsize anymore.
Bill, would you
Good,
choose
Birch, good.
CSI here as well?
Good.
Or
Yeah,
you don't?
Good.
I'm not a big fan of the 1.25, to be honest, and we've actually found that the tip of that actually
It's
has
still medical.
atherectomy and really super tight lesions. We've struggled with 1.25. We did a trial 30 years ago on randomizing small versus large burr, and we found that if the burr to
Click
lumen
inject,
ratio
okay.
was
Click
actually
inject, okay.
less than 0.5, so a 3 millimeter artery only needs a 1.5 burr. So we kinda-
Where is the pressure? Guys, pressure.
Okay,
Not working?
all
Huh?
right. So it looks like
Okay, let's do the
have
hand
you done
injection.
your
Okay.
OCT
No,
yet?
it's just,
We're just,
yeah, we'll do it with the hand injection. Give me a big, yeah. Okay,
okay.
I'm going to do it with the hand injection.
We're
Yeah.
ready for you.
Good.
Are you ready?
Yeah.
It's working?
Yes.
Okay.
You're ready to open. Close. outside. Yeah.
So I know you're
Okay,
gonna.
after the patient, go forward.
Good. We good.
So the distal lesion.
Let's see if there's only, if there is a.
Yeah,
do you-
good flash.
Good flash?
Yep,
Okay.
it's ready.
You can see the OCT?
Yep, it's on the screen.
We can see it on the screen, yeah. Have you been beyond the distal lesion yet, or, I don't know?
Repeat it.
Yes, we didn't see.
Okay,
Dr.
okay.
Kenny, sorry, can you try it again?
Yeah, I'll have to try it again.
Good.
Yeah,
That's around?
Yes.
that should be far enough.
Yeah, good. That's good enough now. Ready? Okay, I'm going now.
Okay.
Enable pull
So
back.
Dr. Kenny, I'm sorry, so it didn't pull back yet, so I changed it to the automatic way. So can you try it again, please?
Okay.
So you can enable.
I'm going to enable. You did
Sure.
not have it on
Yep,
automatic.
I don't
Okay,
touch.
good.
How often, what would you,
Okay, ready?
Kate, what's your best imaging strategy in a case like this? Is it IVUS or OCT? I mean, I'm more comfortable with IVUS, but let's see what you think. But I do believe that even with OCT, you could see the distribution of the calcium so much better. Let me
Yeah,
know
thank
what
you,
you
Dr.
think.
Kenny.
Yeah, I
Beautiful
think
image.
the advantages are you get a rapid overview with, you
Yeah,
really
I see
the
some
pain
fracture.
points for the case very quickly and get good
Yeah, so
characterization
tight
of the
lesion.
calcium.
The
But
calcium-
usually does require enough prep work to get.
Okay,
good
just,
imaging.
tell
I
us-
think we have enough cases in this
Sure.
diffuse disease where we get kind of crummy
One
imaging
second.
that we
So
do tend to use
before I
IVUS
do
in
the
our lab does, and I were
presentation,
just
I
talking
quickly
about
show
that.
you
But
the lesion.
I think if you're
So
really
now,
comfortable
this is
about
the
when it's
proximal lesion.
good
The
enough to
proximal
get
LED.
these
Yeah,
types,
like
either can work.
76 calcium.
Great.
Go to
Hold
this.
on a second. Please
So-
go back and start from the beginning. We were speaking and you guys were explaining the OCT because you don't have a headphone on. So go ahead and tell us what the entire artery. Start from the very beginning and show us what you're seeing, please. Thank you.
Sure. So now this starts from the distal edge, like this part. So now coming the proximal. So now we see the eccentric thick calcium and a small fracture in the border of the calcium and the fibrous plaque. Now you see some fracture, like this is also the dissection. This is a good
Trio
plaque
pocket.
modification at the mid part. But when we come back to the proximal part, so like very thick calcium, like 270 arc. But we cannot
Does
see
it
the
have-
fracture at the proximal part. Because
Trio
just we did a 125 bar at the proximal, but we didn't do the volume dilatation at the proximal part. So, and Dr. Kinney, what do you think? So still 360 calcium at the proximal part.
Yeah, you have 360-degree calcium,
Yeah.
and just by looking at it, to me, the depth is more than, right?
Yes.
Yeah, thickness
Fine.
is more than 1 millimeter. Very thick calcium at the proximal part.
Yeah.
So, I mean, it's
The mid to
really,
distal,
what you're really showing
Yeah.
us is how detailed and what you're learning about the distribution of the calcium, the thickness of the calcium, and understanding all of the issues regarding whether you need to go to a higher burr, what size. OCT is doing that more precisely. So if you could get, we could get you in every lab in the country, then we would all be great in terms of interpreting this. Any comments from the panel? Quick comments so we can get going, because there is another
but,
case as well.
Okay.
Go ahead.
Based on this, I think what do you think we should do?
Yeah.
so
I think we should go with,
See, to the
IVL, I
would
don't
do
know what the panel
lithotripsy to
thinks.
the proximal.
yeah.
do
because
we
then
go with IVL or do we
Yeah.
go with a bigger bar?
IVL.
IVL.
Okay, everyone here
And
is
a
giving you
plot-
IVL. What about you, Antonio? Would you go with a higher burr or IVL?
I think IVL is a more modern approach. I
Modern
agree.
approach, okay.
Yes. And
All right.
yeah, more modern and
Less,
safer approach.
you think it's safer. Do you think it's
Trio is
safer,
good?
Bill?
Actually,
Bill?
the proximal LED size is 3.5.
I think it's
Even
great.
the start of the pullback is 3.0.
Kate, do you
Proximal
agree
LED
with that?
vessel size is 3.5.
Yeah, if I think I can get away with one IVL balloon, then I would do that. If not, then I would use a bigger burr.
There
I
you
have
go.
opened a
If you
trio.
don't,
you know,
if you
yeah,
don't
yeah,
have
but it's
IVL or
because
if
the
it's an
trio is enough
economical
to
issue,
make a
you
fracture.
can
I
use
think.
a high-pressure cutting balloon
Yeah, but on the imaging, there's two types. One was very thick, 360
Yeah.
of superficial calcium, and the area just before the dissection had big nodule. So I think that's the other advantage of IVL, because if you do atherectomy because of the wire bias, you probably
Four
won't
for
touch
six.
the nodule, and that's why I think it's very important.
So I think what Kate said is really good, very important. If you could get away with one IVL, it's just thinking about the costs to the cath lab. You think one IVL balloon will do this, Dr. Kinney? Is that why you're choosing this, or do
Yeah,
you-
so what
and
happened
size?
is, remember when he was doing the OCT, just with my eyeball, I thought it would look like a 3O. I already opened a 3O IVL. So here I'm having difficulty in getting it down. This is exactly where the regular balloon did not open. This is likely 3O. So I'm going to go 3O there. And I think we just use one. We are not going to use two.
Okay.
So this is
But
where we are.
when
We're
you're
doing the
doing an
IVL there.
Impella case like this, the cost becomes a relatively low issue because you already.
Yeah, but I think you always think about cost. At the end of the day, everything is a cash
He's a
register.
very
So-
special patient.
Yeah.
You see that? It's already opened.
Okay, wonderful. So tell us exactly where you chose to go as in front,
So
using
just at
the
if you see here
OCT.
at the level of the diag,
Yeah,
from there, we are coming back. I think we don't need anything here. I didn't see a dog bone. I saw the dog bone earlier in that lesion. So I think we'll still do it because we want a good stent expansion. That's good. 3O, okay?
Were
Okay,
you
done.
able
And
to
now
get
I'm
the
going to come
balloon
to the
down
proximal.
long enough? I thought that you weren't able to get past the critical lesion, or did you?
No, I did. I was able to get. That's why
Okay.
I never took the rotawire out because
Okay.
I knew I had trouble. You see here,
Yeah.
it's way harder to get it back.
Yeah.
Okay.
I saw the guide going in, yeah.
So one thing about IVL is that imaging is key. You have to have the right size, 1-to-1 vessel size, so that you are able to get the right amount down. So same at 4 atmosphere.
So is
Well
this
done.
going to end
Good.
up being a
Done.
full metal jacket from the distal end all the way up to where you're treating here? Is
Yes.
that right? Because we don't have drug-coated balloons. What's everybody else thinking? Is this the right way, the right approach for this
Get us a
patient?
3.5 for the proximal LED 20 balloon. 3.5
Jazz?
20.
Definitely, we need to stand from normal to normal as much as we can. My only concern is that diagonal because of the anterior lateral wall, if we're going to protect it or anything. But other than that, the LAD is feeding that dyskinetic apex.
Jazz?
Length of the stent. The key is getting the luminal gain. Once you have the luminal gain and you're doing atherectomy and IVL,
Not
I would
going, right?
stent,
Yeah. You can play it again, yeah.
from where you really have a distal landing zone to the proximal LED. I wouldn't worry about length.
Antonio?
We have drug-coated balloons in Europe, so we try to avoid
Too many stents.
this full metal jacket. But again, the decision comes after full lesion preparation.
Ready? Picture?
And you may also combine focus stenting and drug-coated balloons, but you
Ready?
don't
Yeah.
have this.
Okay.
I think there's a big mismatch between the distal vessel, distal to the diag.
Absolutely.
And I just wonder whether you could stent to that diag and then watch the patient, maybe bring him back in a little while to see if the vessel's going to get better. I'm really worried about stenting all the way. The other thing is if you just stent to the diag, you haven't precluded the ability to do a lima down the road.
Yeah, and Bill, you might have to
P5.
talk into the microphone because you're very soft-spoken, so everybody could hear you better. But
I'll speak
what's-
louder.
Oh, perfect. What's your plan now? What are you thinking about that diagonal? I mean, I understand you're coming in
I
now
am-
with your balloons, but
Yeah, yeah.
what do you think about that
I think we
diagonal?
have dissection. I don't know, can you?
No,
please
diagonal, we are
elaborate?
going to, yes. So diagonal, we'll try to wire, but the look at the prox to mid LED, we call it AIP, arteries in pieces.
Exactly.
So wiring the diag will be a little challenging, but we'll do it. But let me just make sure the prox LED is fully taken care, and stenting is, I think, where we need everybody's advice. That do we go full metal or do we preserve for the lima in the future? So this is 3.5 going up to 20 atmosphere. Now you see good expansion.
The problem is you have a pretty decent sized dissection right near the diagonal. So I think avoiding
Yes, yes.
stenting in that area will be difficult. So I would protect that with a balloon or
Okay.
something like that when you stent across it.
Okay.
Yeah,
So
for
give me a
sure.
filter wire. So let's wire the diag and stenting. Do we go from normal to normal? So
Well-
even if you think about Lima, there is a significant amount of LAD. Even if we go,
If we
Audio
protect the
call.
Right?
diag, Anu, if we protect the diag with a wire, then we
Mm.
won't be able to use the Godzilla.
Oh,
Because you're
here.
gonna need
Okay.
support, or you think this will go straight?
okay, down. So
Okay,
now get us a 275.
so now
So what we will do?
what's, so.
What do you want to do?
So I think, we have a lot of concern about the tapering of this vessel. So obviously, you'll have to do this in a couple of stages. And the distal vessel beyond the diagonal absolutely needs stenting. It's a small vessel. It's already dissected.
Even if you don't have the drug-coated balloon, I will do my best to stop stenting at the diagonal
I think.
and not go
I-
distal.
I agree. I think Dr. O'Neill's point is critically important because this is not a surgically ineligible patient. If it was an ineligible patient, then I think it's reasonable. But I think in a surgically eligible patient, then he's already had stent failure once. This is very long calcific disease.
And he's
I-
diabetic, by the way.
And he's
Yeah.
diabetic, and I think maybe in the future you could
Give me a
convince him
fielder
to
wire.
fail stents and preserve that option.
Let's,
I know
let's see what
this is
that
a-
distal vessel looks like, because we
Yeah,
can't
There is
tell.
controversy here in the table about where to stop stenting. I think imaging again with the OCT, if you have a big, bad dissection distally, maybe something worth it. Just an
Yeah.
opinion.
Yeah,
it
let's
up.
just see
The
this.
flow
Take it down.
distal is pretty good.
Take it
You
down.
may do some additional balloon dilatation, more distal, but
Yeah.
I think it's. I doubt you're gonna place a 225, a stent long, makes
Yeah,
no
that's
sense.
not a great-
I don't
I
even
agree
think
with
they
that.
should be available on the
Let's
market.
see.
I agree. I think in the
Anu, do you
CTOs, we
know-
get used to leaving those behind, but also you're probably going to stage the right, so you can always just plan to do a relook in a few weeks.
Yeah. Is that your plan too, to stage that right coronary and come back to it at some point, Anu? And that's another reason to kind of say, well, maybe I'll preserve the stenting in that distal area when I
Come
bring
back,
her,
come
when
back.
patient back, you know?
I mean, if you think about this vessel, even after the diag, I think let's take a picture. Now we have done multiple balloon
Yeah.
dilation.
But
It
I
looks,
didn't see you dilate the distal as well as you did the prox. Maybe you did.
No,
I
we
don't know if I
did with the
missed it.
2.5 balloon. We did.
Okay.
Anyway, so let us see how it looks now
Okay.
and then make a final decision. And then you guys can go to the
Beautiful
other room.
wiring,
Dr.
and
Sharma
there
is
must
waiting.
be another, there must
You
be
ready?
another
Yeah.
case, right? So why don't you show us
Yeah, yes,
this?
another case ready. Go.
Oh, you have it sent it.
Yeah, there's a pretty big
I mean, how could you
dissection.
leave that,
No, post
Sorry,
diagonal,
LED
Now
distal.
you're,
but I don't think you need to go that far
no,
down
now
distally.
she's committed now beyond the
Yeah.
diagonal.
Okay.
because
The
of that.
diagonal, beyond the
Yeah,
diagonal
yeah,
is
it's a
type
bad
D
dissection.
yeah.
Your
Okay,
runoff
so
is
what we
poor.
could
You're
do-
gonna
Not a
thrombose
type C
anything you do. I
dissection.
would stent it.
After
Yeah.
the
Let's balloon the
diag
diag.
clears,
2.5, get us a
the
2.12
residual
balloon.
is
We'll just,
fine. It's not a bad
diag will
dissection.
just pre-dilate it and we will put a stent. We'll start stenting around 3 o'clock, just where the pigtail of the Impella. You see that where it crosses?
Yeah, okay. All right, and you still
And
have
then
plenty of
probably
room
we'll put
for,
2 stents.
yeah.
Yeah.
Okay, that's good. Let's go to Dr. Sharma, and then we'll come back to you, because I'd like to see what you end up doing in that diagonal too, because it looks like the dissection plane has taken into that area too.
Okay, we need to show the final OCT. So after you guys left, you saw us wiring here, right?
Yeah, we saw all that, yeah.
We did a gentle balloon of the ostium of the diag for keep it open strategy. This is a 38, 2.538. And
Yeah.
whenever you have a side branch, make sure you cover with 1 stent. No need to have overlapping. So then the risk of losing the side branch is higher, recross is harder at a later stage. Like we said, we are going to stop where the Impella was crossing so that we
Yeah.
have enough space for the Lima for the future. Exactly what we did. And this is another 38 stent. This is a 3.5 and one we did Can we show the rod? So let us see what the angiogram looks like now. This is the final picture.
Oh, very nice. Okay. And
So we're going to show the
very
OCT,
nice.
showed
The
a full
OCT, and
stent
then
apposition.
I
There's
always like
a
to
little
see
bit
the
of
whole thing
dissection. We
without
just
any
did a
wire in
patch.
there.
Yep.
Yeah.
There
We just
go.
did a patch
That's
work,
the
and this
final
is
picture.
the caudal view.
Okay.
You have enough of distal LAD for the lima for the future.
Let's take a look
So
at that
one thing that we are
OCT.
learning, that once you do IVL, there's no need for high pressure balloon dilation, and even post, we didn't have to do any post dilation of the stent once we placed it. If you want to see the OCT, we can show the OCT run.
Yeah, let's see the
Sure,
OCT
so,
because
like-
I like to see what's happening proximal to the stent in the prox LAD as well.
Yeah, so now I show you the proximal up part of the stent. There, I see the fracture
Just stop
behind
there.
the stent, and the stent is well expanded. The area is like 6, 7. And proximally we cannot see because the long ground, but okay. And as the mentioned, this is like small dissection, like 60 degree. But it means there is no LC landing zone. Even after the stent, there's diffuse plaque.
Yeah, we see that.
Yeah, but
Even
a stent is well
of
expanded. The
dissection down
calcified part is well expanded.
there. Okay,
Yeah, that's the OCT.
okay. All right. Thank you, Dr. Kinney. Beautiful case. Thank you so much.